Bismillah ar-Rahman ar-Rahim. Thank you very much for inviting me to this prestigious conference. It's always a pleasure to be among regional and international colleagues in the specialty. In the next 25 minutes, I'm going to share with you some data about the challenges that we meet in the allergy and clinical immunology practice in our area.
Just tell the doctor to just take the settings and allow the whole participants.
I have no disclosures. I'm going to speak about the burden of allergies in our area, the local challenges in food allergy, as well as in airway allergies, the obstacles that we meet in managing inborn errors of immunity, as well as the HIV status in our area, and finally, the unmet needs. The reported overall rates of atopic disease in countries of the Arabian Peninsula are comparable to those in other industrialized countries. However, genetic factors and the high rate of consanguinity in the region may contribute to a higher prevalence of atopic diseases. As you can see, allergy is increasing by the years. And in this study, I will take an example of the Kingdom of Saudi Arabia. As you can see, asthma and rhinoconjunctivitis have increased a lot since in a period of 10 years. I'm going to take a quotation from this Elsevier Atlas Award-winning article that came out from our team in Ain Shams University. It says that the tremendous increase in allergy prevalence cannot simply be explained by the change in public hygiene. And this is against the hygiene hypothesis of atopic diseases, because there are many pre-hygiene communities in our area with sewage contaminated water supplies, helminths, infestations, barefootedness, and poor housing, and still there is a high prevalence of allergic disease. If we go to food allergy, we will find that the incidence and prevalence of food allergy is rising. This is a very recent article that was published in the JACI. The spectrum of food allergens is not identified in some geographic locations, including ours. We mainly depend on surrogate markers of sensitization, such as skin prick testing and specific IgE in our research, rather than food challenge, which gives you a misinterpretation. The level of specific IgE that positively predicts clinical reactivity is not identified for many food allergens. There are many challenges in managing food allergy, especially in the developing world. First, we have a limited number of allergists in our countries. Why? Because allergy is under-recognized as a clinical specialty. Symptoms of food allergy sometimes overlap with those of malnutrition, and looming food and agricultural issues impact the management of food allergy. Worth mentioning is that some major food items in food aid programs are frequently allergenic. We have many diagnostic challenges. For instance, insufficient knowledge about food allergy, not only by parents, but also by some healthcare workers. We need to do good education to our health workers in order to spot the cases of food allergy. Personnel capable of performing oral food challenge are scarce. There is usually a diagnostic lag, especially in infants, and standardized allergen extracts that we buy might not represent our local allergens. There is a big problem of the in vitro test interpretation. Serum-specific IgE results sometimes are misinterpreted by physicians who consider any detectable level as diagnostic, and so put their patients in unnecessary elimination diets. RAS testing without a solid phase and other semi-quantitative techniques are still being used in our area, and component testing, of course, is not available in every country. There are some issues that we should take care of in the food management in respect to local circumstances. Babies with food allergy should continue breastfeeding, never stop. Formulas Optimum for cow's milk allergy, for instance, amino acid or extremely hydrolyzed formulas are expensive and not always available. Soy formulas may be considered in patients with IgE-mediated cow's milk allergy who are not sensitized to soya and who cannot afford other more expensive formulas. Exclusive feeding on rice formula is nutritionally inadequate, and camel milk is under investigation, and I look forward to the results of these tests. In a study on breastfeeding and its relation to allergic disease, you know that this subject has always been a debate between scientists, but a recent study has shown an increasing duration of breastfeeding is associated with decreased prevalence of wheeze due to the presence of higher TGF-beta-1. This is an example in the mother's milk. So consumption was associated with less wheeze at the age of 1 year. It is imperative in low-income settings to weigh the preventive benefits of early introduction of solid food, which is nowadays used for peanuts, for instance, and this should be weighed against the risk of a shorter duration of exclusive breastfeeding on maternal and child health. In our circumstances, I think that prolonging pure breastfeeding would be beneficial. There is inadequate labeling legislation and high level of illiteracy in some locations, so the patients cannot read the labels in the food market to know the ingredients in each food. If we go to the aero allergens and airway allergy, we will find a meta-analysis that evaluated 92 published articles from our area on the incidence or prevalence of asthma and COPD. And the prevalence of asthma was actually 9.38%. And it was variable between different countries. The top countries were Kuwait, Qatar, and Saudi Arabia. And less than this was Egypt, 7.7%, which I think is an underestimation because the methodology is different between the different studies. For instance, if you look at this study on the prevalence of asthma and related symptoms in the Middle East countries, you will find that each country, several studies were cited. And the prevalence in each study is different than the other due to the difference in methodology and the number of patients included. If you let's take an example of Saudi Arabia. One study said it's 8%, while another said 23%. Look at the difference. We have to unify our methodology in research in order to come out with real interpretation. Statistics from the United Arab Emirates indicate that at least 13% of school children, particularly of Emirati descent, suffer from asthma. The most frequently identified risk factors were outdoor and indoor factors exacerbated by the country's rapid urbanization, genetic factors due to consanguinity, the socioeconomic status, and finally the vitamin D deficiency. Levels of allergic rhinitis range between 9 up to 38% in some studies from the area due to shift towards a Western lifestyle. If you look at the top map in this slide, 6 to 7 year olds, the highest levels of allergic rhinitis were spotted in the Saudi Arabia, Egypt, as well as Oman, while in the group age of 13 to 14 years, the top countries were Iran and Oman, as well as Lebanon, while it was less in Egypt and in Syria. Nasal allergies as well were studied in a study called Allergies in the Middle East survey. The overall prevalence was 10%. This was dependent on physician-diagnosed allergic rhinitis, not upon self-report, and it ranged between countries. The snapshot program evaluated the levels of allergic rhinitis in 5 Middle Eastern countries, including Egypt, Turkey, and the Gulf cluster, and it revealed lesser levels of lesser prevalence of allergic rhinitis. But it stated that its burden is actually higher than in the Western countries because of the severity and control significantly that leads to significantly impaired quality of life, quality of sleep, and daily activities. Concerning some allergens, aeroallergens in the area, this study from Iran evaluated tree pollen grains in 23 countries of the Middle East. And it found that olive tree is common in Turkey, Palestine, and Israel, while sycamore tree was the most common pollen in Iran. And it said that due to the uneven geographical distribution of these trees, it is difficult to accurately select the appropriate extracts for skin prick testing. From Egypt, we studied a huge number of patients with asthma and allergic rhinitis to look for their sensitizing allergens. House dust mite was found to be the sensitizing agent in 24% of our patients, while molds were detected in 45% of patients with allergy in the terms of bronchial asthma. Cockroach allergens were common, especially in moderate to severe asthma, more than mild, in the slum areas of Egypt. But these studies did not look for the general population. We studied only physician-diagnosed asthma and allergic rhinitis. That's why you find a very high prevalence. Asthma control in our area is not very good. The asthma study found that poor control was detected in 30% of cases of asthmatics in the Middle East, by the asthma control test and the GINA testing, and that 80% of the patients having risk factors for future exacerbation. Why? Why is there obstacles in airway allergy treatment that lead to such poor control? Because we depend on symptom-based rather than disease-based approach in the treatment, with tendency for acute rather than regular care. Also, the cost of inhalers and immunotherapy is another obstacle. Patients' cultural attitudes toward inhalers, adherence, especially in the adolescent period, and of course, the expanding problem of tobacco smoke exposure, as well as air pollution. When they looked for the burden of allergic disease in our area, they found that they studied 7 risk factors. They found that smoking, ambient particulate matter exposure in air pollution, and household air pollution were the main risk factors for poor control of asthma and COPD. For instance, the estimated prevalence of tobacco smoking in Egypt in 2010 was 22%, and I can assure you that it has increased tremendously after this year. It's now much higher than this. Efforts to control tobacco smoking are available, but they are inadequate. We conducted a research on the pregnant women during delivery to see the cord blood cotinine level, which is the main nicotine metabolite, and we found huge levels in active smoker mothers and also in passive smoking mothers. But what was astonishing is that women who did not smoke ever, and their husbands never, or any household contact was a smoker, so they said we are not exposed to tobacco smoke, still had levels of cotinine in their cord blood. And by taking a good history, we found that these women were exposed to tobacco smoke in the vehicles that during their journey to the maternity hospital, or even inside the maternity hospital, and they delivered this cotinine to their infants. Of course, the expanding trend of water pipe, the nargila or shisha, that is present among our adolescents is a big problem. The aerosol of water pipe smoke contains high concentration of carbon monoxide, nicotine, tar, and heavy metals, and these levels are as high or even higher than those of cigarette smoke. Concerning the particulate matter pollution or air pollution in our area, we will find that the green quadrangles are those of the Middle East and North Africa. And as you can see, this solid line represents the levels, the expected levels of exposure. Our levels of pollution are higher than this median level, together with Southeast Asia, other parts of Asia. But countries such as the US, West European countries, and even Latin America are below the line. We are above the line, and it is rising, the levels of pollution. We shared our unit with a multinational cohort study to evaluate the effect of COVID-19 pandemic on the asthma control in children as part of the pediatric asthma real-life program. And we found that children with asthma are not disproportionately affected by COVID-19. The red color is for the asthmatic children, and the blue is for the normal children in the study. The dark bars represent the year 2019 before the pandemic, and the light bars represent the pandemic years. And as you can see, the upper and lower respiratory tract infections, the febrile episodes, emergency visits, and hospital admissions were less during the pandemic due to the lockdown. And this was translated into less number of asthma attacks, increased better asthma control, and better respiratory function testing. If we go to the inborn errors of immunity or primary immune deficiencies in our area, we will find that our populations are of different ethnic origins. Few of our countries have competent national registries or advanced clinical immunology services that provide efficient genetic testing and stem cell transplantation. Of course, consanguineous marriage lead to high rates of autosomal recessive PID disorders. These are the levels of consanguineous marriage. The darker the color of the country, the more consanguinity, such as Sudan, Jordan, followed by Saudi Arabia and Algeria. As you can see, we have high levels of consanguinity compared to other parts of the world. And this is translated into different pattern of immune deficiencies. The red bars represent the predominant antibody deficiencies, while the blue represent the, for instance, the combined immune deficiencies. As you can see in the European Society of Immune Deficiency Registry and in Turkey, the most common are the predominant antibody deficiencies. But in our countries, the blue lines supervene, showing higher levels of combined immune deficiencies and well-defined syndromes, and this is due to the consanguinity in our countries. Establishment of a primary immunodeficiency network in our region is essential for promoting collaborations and experience sharing. I hope we can accomplish this one day. Of course, in combined immune deficiencies, the type of mutations vary in our countries from other parts of the world. For instance, MHC class 2 deficiency and RAG1 and 2 mutations are common in our area, represented by the blue lines, in comparison to the US net, which is represented by the red bars, and for instance, Asia, the green bars. In Turkey, it is echoed the same. The RAG1 and 2 are the most common, as well as Artemis and interleukin-2 receptor mutations. And still, 57% of patients are not, the mutation is not recognized. Concerning hematopoietic stem cell transplantation, Saudi Arabia has made a good advance in this domain. And a recent study shows that they have already done more than 6,000 transplants. Most of them are allogenic, especially in children, 90% allogenic, while in adults, 60% are allogenic, more than autologous. And most of the indications of transplants are hematologic diseases and hematologic malignancies. And only 10% belong to the SCID. The same is in other countries of the Middle East. Only 13% of hematopoietic stem cell transplants belong to the PID, to the primary immune deficiency, but it is rising. The blue line shows that the number of transplants are rising with years. In our country as well, the number of transplants increased a lot between 1997 and 2017. 16% of our cases are allogenic, only 40% are autologous. And concerning haploidentical transplantation, it is rare in our country. It didn't rise much. And those only a few cases of primary immune deficiency, the rest are hematologic indications. Why are our rates lesser than in other parts of the world? The main problem in Egypt, for instance, is financial. The probability to have an HLA matched donor is decreasing as families are now getting smaller. Less than 3% of donors listed in international registries are of Oriental origin, which makes it difficult to find a match for our patients. Also, we have in Egypt a problem of liver toxicity and veno-occlusive disease due to schistosomiasis and hepatitis C. Many patients also find it difficult to comply with post-transplant hygienic rules. This is a beautiful article from Oman that shows the main problems, actually. High mortality due to diagnostic lag, complex phenotypes, polymicrobial infections at diagnosis before even doing the transplant, late access to immune reconstitutional therapy, and unavailability of a newborn screening program, which is very mandatory in our area. We are trying to narrow the gap between our area, between the Middle East and North Africa, and between the global levels. So these are the teams of hematopoietic stem cell transplantation in our countries. The best, the larger number of teams in Saudi Arabia, 7, which is followed by Iran, Egypt, and then Algeria. These are for the allogenic. Concerning the autologous, we are all the same, except that Tunisia and Beirut and Jordan has made some more cases of autologous transplantation. Narrowing the gap also revealed that in every part of the world, worldwide, as you can see, the autologous is more common than the nowadays than the allogenic, which is the reverse in our area. We make allogenic more than autologous because it's easier to perform. And also, most of our transplants are from related donors. We do not take from other persons outside the family. It has to be a family donor. As you can see, the dotted lines are of the Middle East and the Emirates area, while those are the global trends. Also, global cord blood is increasing now. They use the cord blood much more than ours. And also the haploidentical is less, but it's a little bit rising in our countries than the global trends. Another problem is vaccination, obligatory vaccination in cases of primary immune deficiency. Patients who are immune deficient are increased risk of vaccine-associated poliomyelitis and prolonged asymptomatic excretion of immune deficiency-associated vaccine-derived polio, which we call the IVDPV. And this can persist for years, despite the immunoglobulin replacement therapy. And in a case report, it was only from Iran, it was only cleared by successful transplant. The problem of BCGiosis, you know that BCG vaccination is compulsory at birth in some countries, including Egypt, at birth. And this leads to a high level of morbidity and mortality. And I think the best recommendation is that until safer and more efficient anti-tuberculosis vaccines and newborn screening programs become available, delay in BCG vaccination should be considered, especially that vaccination at birth carries a lower survival probability than vaccination after 1 month in these cases. Concerning HIV, many countries in the MENA region have put significant effort into scaling up the response to this growing epidemic, while in others, the response is slower due to denial, stigma, and reluctance to address such a sensitive issue. The HIV epidemic in the MENA region is still at controllable level, and this opportunity should not be missed. If you look here in this graph, you will find that in the MENA region, although the newly diagnosed cases, the blue bar, are low, but the AIDS-related deaths are high. And this is also present in Eastern Europe. But other countries of the world, you will find that the newly diagnosed cases, as well as the deaths, have decreased a lot because they really address the problem and they do not deny it. And this was reflected on the number of publications from our area. With the exception of Iran and Pakistan, all the publications are low. Next to them is Egypt, Saudi Arabia, and Sudan. We have to address this problem before it's too late. Finally, our unmet needs is that we have to have our own strategies of health recommendations. Why? Because not one size fits all, because strategies, global strategies sometimes do not fit variations in our area. Registries are not adequately implemented, which hinders estimation of the real burden of allergy and immunology disorders. And allergy education should be tailored to the social and cultural background of our population. I wish to acknowledge the unit, the Pediatric Allergy and Immunology and Rheumatology unit, which I'm proud to work in. It was founded by Professor Yahya Al-Gamal, late Professor Yahya Al-Gamal. 33 years ago, he started this specialty in pediatrics in our country and the area. He unfortunately passed away due to COVID-19 last year. May Allah bless his soul. Thank you very much for your attention.